Prior to vessel mapping, make sure you've placed a tourniquet on the patient's arm. Assess and measure the superficial cephalic vein, measuring the proximal, mid, and distal locations in the upper arm. During this time, check for flow-limiting central venous stenosis. Then repeat the screening for the basilic vein in the proximal, mid, and distal portions of the upper arm. In this case, we see the candidate cephalic is 2.7 millimeters in diameter and the basilic is 4.7 millimeters in diameter. So they do meet the initial requirements, and we can continue screening the patient to see if they are a candidate. If the patient does not have either a cephalic or basilic vein measuring at least 2.5 millimeters in diameter, the patient does not meet the minimum requirements and is not a candidate. In this case, we see that the candidate does have a perforator, but it has a C-shaped curve to it. This perforator is considered tortuous, and the patient would not be considered an ideal candidate. Make note of the tortuosity and discuss it with the physician. In some cases, as you follow the cephalic or basilic down to the proximal forearm, you may not see a perforator communicating from the superficial system to the deep system. If a perforator is not present, this patient would not be a candidate. At the proximal forearm, where you've identified the perforator, rotate your probe to the long axis to determine if the candidate has a cephalic dominant outflow, as shown here, or a basilic dominant outflow, as shown here. Flow will predominantly travel to the larger outflow vein and in line with the perforator configuration. Assess arterial inflow just above the elbow crease. Place the probe to locate the brachial artery and measure. The brachial artery must measure at least 2 millimeters in diameter for the patient to be a candidate. The next step is to confirm the patient has a perforator. Follow the cephalic or basilic down to the proximal forearm. You will see the perforator dive down from the cephalic or basilic as it meets the median cubital. This is where there is communication between the deep veins to the superficial veins. In this case, we can quickly identify the patient has a perforator that it is straight and communicating from the deep system to the superficial system. We measure the perforator, and it is 3.1 millimeters in diameter, so we can continue screening this patient to determine if they are a candidate. Assess arterial inflow just above the elbow crease. Place the probe to locate the brachial artery and measure. The brachial artery must measure at least 2 millimeters in diameter for the patient to be a candidate. Only the brachial artery should be used for arterial access. At the same time, measure the paired brachial veins, as these can be potential access points for the device for the physician. In this patient, we see the brachial artery is 3.1 millimeters in diameter. The lateral brachial vein is 2.5 millimeters in diameter, and the medial brachial vein is 1.4 millimeters in diameter. The radial assessment should be taken immediately after the perforator and not too distal down the arm. Measure the radial artery and paired radial veins. Also, check for triphasic flow and calcium. After the radial takeoff, but before the interosseous takeoff. The transition of the common ulnar into the interosseous vessels looks like this. The stacked ulnar vein, artery, vein will change obvious orientation from an angle or a vertical stack to a horizontal or flat. You'll need to move more proximal to take the measurement of the ulnar artery and ulnar veins. After taking the measurement of the ulnar artery and ulnar veins, check for triphasic flow and calcium.